Hello everybody, this is the overview video for Module 5A. And in this module we're going to look at acne and some of its variants. You're going to read up about the dermatoscopy of circles, pseudopods and clods using the Kepplerian terminology. Now, in the acne side, if you've read through this particular module, you'll see there's the various variants of acne and acne scarring. There's pyoderma faciale, which some people put as a variant of rosacea, but I think it comes up well in this particular module as well. The dermatoscopy of pseudopods is important. Normally, if you see them, it's either a reed or spitz nevus or it's a melanoma. So they're an important structure to be able to recognize. In the module webinar that we have on the Monday night, we'll look through basically drugs that cause or make acne worse. We'll look at acne fulminans and the Sappho syndrome. They're rare, but you've got to know how to manage them. That's what distinguishes a dermatologist from someone who really doesn't know enough about acne. You'll recognize these syndromes for what they are. We'll probably have a look at the polycystic ovary syndrome, because not only do these patients have acne, they may have other features of hirsutism, they may have some other skin lesions as well, such as acanthosis nigricans. So we'll try and look at that and some of the tests that you should do. We'll look at some examples of the follicular occlusion triad syndrome. And this is where you can have cystic acne, hidradenitis suppurativa, and dissecting cellulitis of the scalp. And in the webinar, we're going to primarily concern ourselves there with gray circles. I'm hoping you've had a chance to look through the videos on circles beforehand. But we're going to concentrate on gray circles and the significance of them. I think we may do a little bit about white circles too, but we'll certainly be mainly concentrating on that. And we'll look at reed nevi if only to bring out some of the features of pseudopods. If you've had time to go through this particular module, you should look at the video. It'll go through all the images that were in the My Skin Consult site where the acne module initially was presented, and it will describe them. The sections down here, dermnet and acne fulminans, it's well worth having a little look at that particular reference. Remember that in acne, the initial lesion is the microcomedone, the blockage of the opening of the hair follicles. Generally, there's some degree of hyperplasia of cells here. The question of what the pigmented material is dubious, well, debatable. Some people feel it's melanin in cells, others feel it's oxidized sebaceous material, and I think the latter is probably correct. Our drug therapy for mild acne really is based on retinoids, and we're going to have a little chat further down here on retinoids, both topically and systemically. Because it's the systemic therapy with isotretinoin that really has made all the difference in the management of cystic acne. This is a young kid with acne fulminans. You can see it's very extensive, the acne on the back, and if we had a close-up here, you'd see that some of these lesions look like pyogenic granulomas. The important thing here is oral steroids plus some isotretinoin, and go slowly with the isotretinoin with its introduction. It's the steroids first to get this inflammatory acne under good control or under some control, and then introduce your oral retinoids. But we'll discuss that in the main webinar. Little thing in dermnet and polycystic ovary syndrome, try and have a little look at that. The reference in dermnet to isotretinoin, it's quite good too. It goes through all the important side effects that you have to know something about. That little video was on acne treatment that we did. Again, it's a summary of both the topical therapies and the systemic therapy with isotretinoin. You can get acne at other ages, neonatal acne, generally just due to maternal hormone effects, and it's self-limiting. If you start to get infantile acne, look at the child carefully, just make sure that it doesn't have one of the congenital adrenal syndromes or some other reason to be developing androgenic hormones that are causing acne at that stage. Acne scarring is a big problem from the point of view of trying to ameliorate it. We can nowadays try and prevent it if we get into acne early, and the first sign of scarring, put people on isotretinoin to get them settled down. But we've still got people who get significant acne scarring, both the ice pick scar type, which is mainly what we're seeing here, and some that are just a depression of the epidermis. Sometimes the epidermis is held down by adhesions, and you can do subdermal, what they call subcision, where you take a cutting needle, stick it under the area that's held down, and cut the attachments, the collagen in the dermis, and allow it to come up. Fillers can be used. These are generally better just punched out. Hidradenitis suppurativa is discussed in this section as well. This is a difficult condition. We'll deal with it in the main webinar under the follicular occlusion triad. But if you've got time, have a little read both on Downnet and perhaps eMedicine on hidradenitis suppurativa. Now, the dermatoscopy topics that you should go over in this module are the videos on circles, and if we just bring this particular image up here, if these were all joined together, we'd call that line a reticular network. But circles are usually separated lesions like this. There are different colors. The different colors signify different conditions. White circles, for instance, usually represent keratin, the opening of hair follicles, and you'll see them with solar keratosis, SCC, KA. You'll also see follicular plugging in conditions such as lupus, erythematosus. So if you're looking at lupus, you'll see white circles. But primarily solar keratosis, SCC, and KA and SCC in situ as well. The brown circles, you can see them in all of these. Seborrheic keratoses, dermatofibromas, though again that's usually a reticular network that's around the outside of the white pigmented area. Solar lentigo, again, it's not melanocytes here. It's basically an increase in melanin in keratinocytes. But brown circles are also part of a Clark nevus. The gray circle, these are the ones that we're going to talk about in the webinar itself, so I'm not going to go over these, but we'll be looking at these four conditions. Lichen planus-like keratosis, the LPLK, the pigmented solar keratosis, l'indigo maligna, and pigmented IEC. Now, we'll do those circles later. Pseudopods, I've already mentioned that they are significant. Reed nevi, spitz nevi, or melanoma. The main point is that if the pseudopods are all around the outside of the lesion and you've got lines radial peripheral, then it's likely to be a Reed nevus. If it's segmental, the pseudopods and the lines radial peripheral, then it's likely to be a melanoma. The last one was on clods. Now again, different colors of clods. Again, we'll just have a quick look at this one here. We've said that clods are bigger than dots, can vary in size and shape. And we've said that color is the best differentiating feature. We've said blue clods tend to signify BCC or melanoma. and white and orange clods are generally, and sometimes some brown ones, are generally seen in seborrheic keratoses, but you can also get orange clods in some basal cell skin cancers. The red and purple ones are the hemangiomas, yellow SEBKs, white in SEBKs, because there you're normally talking about milia. That's what gives you the white clod. So SEBKs, some congenital nevi, you can get milia and BCCs. Rarely you can get milia and melanoma. That's why it's way out at that end. The brown clods, various types of nevi, but also in SEBK. The black clods, usually a thrombosed hemangioma. And we said the blue clods with BCC and melanoma. Go through the video on that, and it'll take you through the various points on clods there. The tutorial topic, this was on histiocytosis. Now, it's a big area, the histiocytosis, and there's a whole variety, that generally Langerhans cells histiocytosis are the ones that we're concerned about, but there are other histiocytic lesions, such as the xanthogranulomas that aren't related to Langerhans histiocytes. But this, I think these Hoff centerfolds still work, the links with these. Certainly there's some additional pictures here to have a look at. And the terminology has changed. There's a good lecture here by Earl Gusak as part of the MD Live lecture series on the histiocytosis. Just click that link if you've got time. I mean, it's about an hour long, but it's a very good overview of the histiocytic syndromes. Just looking at this particular lady, by the way, initially it was thought, some of her papules that she might have had Darius disease, but she was also getting hemorrhage here, as well as keratotic brown papules on the abdominal and chest wall just underneath the breasts. And biopsies showed that these were tumors of Langerhans cells, histiocytes. The drug and treatment topic, I hope to do this in the actual webinar itself. We'll have a little look at the topical retinoids and what they can do. And we'll also get another slide up there on isotretinoin and have a little chat about the side effects of isotretinoin as well. And we didn't get a chance to do this case the last time. There is a case in Global Skin Atlas of dermatitis herpetiformis. Worth having a look at it. The blisters are a lot more intact than you often see in DH. Usually the blisters are smaller in DH and they're quite itchy, and you tend to traumatize them. And usually they're around the elbows, the knees, the buttocks. But this was a case from Kieran Nabar on dermatitis herpetiformis. So well worth having a little look at this particular case. And if we've got the time, we'll have a little chat about dermatitis herpetiformis in the main webinar itself. Okay, that's a quick overview of this module and the topics that we'll do in the live webinar. So I hope to see you there. Bye-bye.